Hello, let's talk about injection frequency. What's optimal? What's suboptimal? What's realistic? What's unrealistic? So, let's clear this up. When we first started the clinic, we adhered to the manufacturing guidelines because, funnily enough, that seemed like the safest, most logical way of prescribing testosterone. And obviously, before releasing guidelines, they did their research and they came up with some crazy ideas. Libido every 12 weeks, Testosterone every 3 weeks, Enanthate every 3 weeks. Ooh, now if you've been around long enough, you will know that that does not work. You don't have to have an in-depth knowledge of pharmacokinetics and pharmacodynamics to realize that, half-lives, no, doesn't make sense, does it? So, we did show due diligence. We did prescribe as per manufacturing guidelines, and unfortunately, people experienced negative peaks and troughs, hence the change to microdosing. So the evolution of microdosing. We switched from libido to enanthate and now cypionate. They're essentially identical. Cypionate has a extra carbon atom which makes the half-life marginally longer, but it's irrelevant, quite frankly. The benefit of cypionate is the fluidity of the oil. It's olive oil, heart healthy. I'm joking. And it does not have the preservative chlorobutylene in it, which does cause a few issues if injecting subcutaneously. And if you follow these video logs, then you'll realize that I believe that subcutaneous injections are the future. They are less painful and they cause a decrease in aromatization that you do get with intramuscular injections. What we are trying to do is slow the absorption down to prevent that spike of both free testosterone and estrogen and potentially DHT. But the DHT thing's interesting, which we might touch on in a minute. So, microdosing, the evolution of microdosing. Enanthate. Well, we followed the American model and injected every 3.5 days. That worked for a lot of people. It didn't work for some. Why didn't it work for some? Because the half-life of cypionate and enanthate is around 5 to 9 days, so it should work. You should get stable levels after 5 half-lives. If only it were that simple. What factors influence the half-life, absorption, stability levels? Well, the big one's SHBG. So, not many people know about SHBG. Some people think it's irrelevant. Well, they're idiots. SHBG, glycoprotein produced by the liver. Ergo, you need a nice healthy liver in order to produce SHBG. So what happens to the testosterone when you inject it? Well, it goes into the vascular system and it goes to the liver. What happens in the liver? The carbon atoms are cleaved and you essentially release testosterone. Beautiful testosterone. What happens in the liver as well? You produce SHBG and you also produce the aromatase enzyme. Da, da, da. So you are exposing that testosterone to SHBG and the aromatase enzyme. Testosterone binds to SHBG. Why does it bind to SHBG? Well, it binds to SHBG because the half-life of testosterone is very short. It's been about 10 minutes and 100 minutes. So if you produce testosterone and it doesn't bind to SHBG, then it's excreted out of your body. Boom. So we don't want that. We want testosterone 24/7 to help facilitate growth and repair. So SHBG acts as a buffer. Also, it helps testosterone go through the cell membrane and helps expression within the cell. So you want a nice healthy SHBG. And actually a sign of a healthy protocol is a normal SHBG. So what we find with guys with high SHBGs, they tend to come down with testosterone, and guys with low SHBGs, they tend to come up with testosterone if you are prescribed properly and optimized. However, if the causative factor for a low SHBG, so you're a chunky monkey, got increased insulin resistance, or you have hypothyroidism, then your SHBG will not rise even when optimized. So you have to bear in mind that there are other factors involved, but a sign of a good protocol, excluding those other issues, is your SHBG normalizes. So testosterone binds to SHBG. It has a higher affinity for testosterone than it does for estrogen. So you're binding the testosterone, you're exposing it to the aromatase enzyme, and so ergo you are creating estrogen. So the aim of TRT is normalization. It is to actually really mimic your natural physiology as close as possible. So we do that through normalizing, balancing hormones. But the actual physiological processes are slightly squiffy. So you are sending the testosterone ester to the liver, and ergo you are exposing it to SHBG and the aromatase enzyme. So it's not quite as natural as we'd like it. The DHT thing's interesting, okay. So yeah, the old transscrotal testosterone guys love their DHT, and who doesn't love a bit of DHT? It makes sense that you want to produce some testosterone in the testicles, hopefully by the testicles with HCG. But if you're rubbing testosterone onto your testicles, then you are ergo going to have a higher concentration of testosterone in that area. And guess what's in that area? 5-alpha reductase, which converts to DHT. Ergo, if you have a higher concentration of testosterone, either through intratesticular production of testosterone through HCG use or transscrotal testosterone, you will have a slight increase in DHT. So those guys who have testosterone monotherapy without HCG, one could hypothesize that you have a slight decrease in DHT because the concentration, even when optimized, is going to be slightly less. Is it clinically significant? Is it statistically significant? Probably not, but quite possibly. So the guys that have optimized levels but still have libido issues, and there are no other sort of obvious causative factors, it may well be the fact that you have a relative decrease in DHT. So what can you do? Well, at the Men's Health Clinic, we have access to Proviron, which is called Mysterolone. So we are using it in our guys who have moderately elevated estrogen that do not warrant an aromatase inhibitor. and the guys that have a slightly low libido for a non-obvious cause. So it's interesting. So we shall see. And obviously we are using it primarily for the high SHBG guys, because it also binds to SHBG. So binding to SHBG means that you are going to free up some testosterone. So, my God, I've just gone off on a rant, all over the place. Okay, let's get back to injection frequency. Now, I recommend either daily injections or every other day injections. That is my starting standard protocol. Sometimes it comes down to realistic expectations, patient compliance, but if I could, I would tell everybody to inject daily. Oh no, daily injections. No big deal. Put the kettle on, bang, bing, bang, bosh, you are there, you're done. Why are we injecting daily rather than every other day? Because having a normal, moderate SHBG means you don't need to inject daily per se to achieve stable levels. It takes away that thought process. Wake up, is it my HCG day or is it my HCG and testosterone day? Yeah, every day is testosterone and HCG day. So actually from a patient compliance perspective, dailies is actually easier than every other day. Just that thought process. Bing, bang, bosh. Wake up, pin, done. So we have found through experience that microdosing testosterone and HCG is the most effective way of achieving stable levels. Now, that's not rocket science. And it shouldn't be rocket science, and it shouldn't be controversial. There's a group of clinicians that say that you don't need to worry about SHBG, and you should only practice evidence-based medicine. And yes, you should only practice evidence-based medicine, but when the quality of the evidence is atrocious, and it's not statistically significant, common sense, knowledge about biology, biochemistry, physiology, pharmacology should take precedence over a poorly designed study. So these guys who just say, keep banging up the dose until you feel amazing, recommend daily or every other day injections. But pharmacokinetics say, well, actually, you don't need to do that. So why are they recommending that? They're actually negating the SHBG issue, but they're doing it surreptitiously. So they are essentially saying, you don't need to worry about SHBG. SHBG is irrelevant because you could just keep upping the dose. Now, by chance, by luck, is it Machiavellian? I don't know. Daily injections is the most effective way of not causing a big issue with your SHBG. What tanks SHBG? Overaggressive protocols, erratic protocols, which is where that comes in. Because actually what happens with a constant physiological state, your body does make the necessary adaptations. So your SHBG won't have quite such a significant drop because you are on stable levels. So that's interesting. Follow the science, don't follow the science, make your mind up, guys. So you don't think you need to worry about SHBG, then why you are advising people to inject every day when pharmacokinetics state you don't need to? So yeah, practice evidence-based medicine. All right, guys. I think I've banged on long enough. What else is there to say? Logical, methodical,